Short stature is a very common pediatric problem, which we encounter almost several times in our OPD. And a lot of children and parents are concerned about the height of the child, and many of the times these causes or the reasons they are concerned is sometimes there may not be anything major and all they need is counseling, and many a times there can be some pathological causes of short stature where a pediatrician or a physician needs to act so that the child can attain his normal height. So before going to what is short stature and everything, one must know what is the normal growth potential of the child, right? So before knowing that whether the child is short or tall or whatever, we should know what is the normal growth potential of the child, right? So by definition, short stature, you can get a short note on it. It is failure to gain height as compared to his or her peer groups. This is a layman definition which we use for short stature, right? So by definition, it is less than the third centile. On the growth chart, when we use it, it is less than the third centile or less than -2 standard deviation. Remember, short stature is a vague term and not stunting. So stunting is when we say less than -2 and severe stunting is less than -3. But your short stature is less than -2. So commonly we use the term short stature when the child presents as not growing height. That is the complaint, and that is when we call it short stature. Or you can also use mid-parental height. I will discuss about the concept of mid-parental height in further slides. And abnormally slow growth velocity. We'll also discuss about what is growth velocity. On the 2 percentile charts, I hope you know about growth charts. So whenever the child crosses 2 percentile charts downwards, that may also be considered as short stature. So these are various definitions that have been used. However, the most common one still remains less than -2 standard deviation or less than the third centile, right? So we discussed it is less than -2, it is less than third centile. One is, crossing growth curves that I'll just show you. Another is an abnormal growth velocity. So we must know that the growth velocity is the velocity with which the growth occurs per year. So growth velocity, as we all know and we can see very well from this chart, is different at various age groups, right? So you must be aware that during the first year there is maximum growth potential, right? So during the first year, the growth velocity is approximately 25 centimeter per year. That is at birth, the length is 50 centimeter. By 1 year, it is 75 centimeter, right? So the growth velocity or the number of centimeters or length or height the child will gain per year. So in the first year, it is maximum 25 centimeter. This is just an estimate. In second year, it is approximately 12 to 13 centimeter per year. So as and when the child grows after the first year, you can very well see the growth velocity slows down. So from 5 years to puberty, it is 5 centimeter per year. So when you monitor the growth of the child, you do have to consider that the parents will have undue expectation that the child was growing very well in the first year. In the first year, he was born at 3 kg, 50 centimeters, and then he suddenly became 10 kg at 1 year, and now he's growing so slowly. So that is the way growth occurs. That first year, growth will be tremendous. There will be tremendous growth, both in weight and in height. However, by the second year, third year, fifth year, till puberty, the growth is going to slow down, right? So I hope you understand this concept. It is very important to the concept of growth, that this is actually a growth spurt which occurs this time, and the next growth spurt is going to occur at puberty. And there is again going to be an increase in weight, tremendous increase in weight, tremendous increase in height. So one should be aware of the concept of normal growth velocity so that we are able to detect what is abnormal, right? Okay, so this is what is the height velocity or the growth velocity. So what you will do is, you suppose calculate the height today, say T1, then you calculate it at a later time, say after 6 months, okay, that is T2. तो जितना उसका difference है, that is T2 minus T1, whatever centimeter it is, divided by the number of months between T2 and T1, say 6 months, into 12. That will give you your growth velocity per year. Okay, this is how you calculate the growth velocity. So whenever a child comes to you, first take the height of the child. We'll discuss in detail what is the approach. Take the height, how to take the height, I will tell you. Okay, so take the height. Say he comes to you after another visit, say 3 months, 6 months. Then again take the height. Then subtract that height, T2 minus T1. See the number of months between those two heights and then multiply it. Okay, so this is essentially the concept I was trying to explain to you, that initially the growth is, 25 centimeter per year, tremendous growth at 1 year of age. Okay, then it slowly slows down. So from 5 years to say puberty, the growth is slow. You can see this curve very well, right? And then there is a peak. So this peak is the pubertal spurt. So as we know, puberty is earlier in girls. In females, it's about 10 to 12 years of age. And in males, the height is at a later stage. The peaks at the later stage. So girls get their growth potential maximum by 12, 14 years of age, and then it kind of slows down. And males, that is boys, they get their growth spurt a bit late. So you can see the growth spurt is a bit late, but it is a higher growth spurt. Okay, this is the higher growth spurt from 14 to 16 years of age. And then slowly by 18 years of age, it slows down. So we need to realize that this is the window, right? From 10 to 14 in say girls averagely, and from 14 to say 18 in boys, where we need to act if we have to find some pathological cause. Because once the epiphysis fuses, I hope you know the concept of epiphyseal closure. So once your epiphyses close by the age of 16 in girls and 18 in boys, there is not much potential for growth, right? Okay, so this is briefly when you get a child and the attendant says that my child is short, what do you do about it? Okay, so first you calculate the chronological age. So chronological age means that, okay, if you have any questions till now, you can just put in the question box. We'll just take 2 minutes for that. If anybody has a question. I hope all of you are awake. It's a bright morning. Okay, so we'll go ahead and yeah. So when you get the child and the parents say that my child is short, so what do you do about it? So you first ask them the date of the birth, okay, and see the chronological age. A very important or essential tip would be, if they don't remember the date of the birth, you can ask the year of the birth and the month of the birth. In case they don't do that, you can check from the vaccination card, from the birth card, from the Aadhaar card. So nowadays, most of the parents do have a date of birth, but still, if you don't find it, at least get the year of birth. Okay, so that will help you in the chronological age. Okay, because mostly when these children will present to you, they would either be, between 5 to 10 years of age or beyond 10 years of age, because usually before that, parents are quite happy with children growing well. So usually, 8 to 10 year of child not growing well, that is the kind of child you get. So mostly they will have a vaccination card or some school card. So date of birth you can get from there. Okay, so first point written well, take the date of birth, get the chronological age right. So either they will say he is 4 years, but actually he's 6 years. So, just confirm the date of birth. Okay. So the next thing is take the history. Okay, take the history. What is the history like? Is he short? What do they feel? That is he short since when? Is he not growing well after a particular illness? That maybe he had jaundice, maybe he had some polyuria, polydipsia, maybe he has some cardiac complaints. Since when is he not growing well? And what is the systemic complaint? So, all these complaints you will ask. So, cardiac, renal, GIT, CNS, all of these can contribute, and there can be several others. I have just mentioned the few salient ones where one can. Okay, there is some question. Okay, so if a child is born prematurely, will he be always short-statured? This is one question somebody has asked. Okay. So the thing is, for a child who is born premature, you have to, I didn't include that question. This is somebody has asked. Uh, he will not always be short because, one second, I'll go back. Yeah. So when you calculate the chronological age here, I didn't mention that, but so when you mention the chronological age, when we take for a premature child, we take the corrected gestation age. Say he was born 34 weeks. Okay. So when he is going to be 40 weeks, from there we are going to count his date of birth. Right. So we all know that the full term baby is your 40 weeks. Right. So suppose he was born, say, 34 weeks. So we are going to subtract those 6 weeks from his age. Or what you can do is when he turned 6 weeks, say he was born, say, to, 6 weeks back. So from today, he is going to be counted as day one of birth. Does this answer your question? So for a chronological, for a patient who is premature, we will calculate the corrected gestation age. This is the concept of corrected gestation age. Okay, yeah. So another point I think we can add here is calculate the corrected gestation age. That's a good question. Okay. So another thing is once we've started about prematurity, I think I'd like to add that there are patients who are born premature and then there are patients who are born SGA, right? So you know the difference between premature and SGA. Premature is somebody who is born your before 40, before your 37 completed age. So somebody has asked what is chronological age. So chronological age is just the age of the child. Okay, it is same. So yeah, so we are talking about prematurity. Okay, so premature is somebody who is born before 37 completed weeks, and small for gestation is when the baby is born at term or at whatever age he is, but his weight is less for that age. Okay, so suppose he was born at say 40 weeks, but his weight is 1 kg, 2 kg. So what do we expect? Obviously, his height is also going to be less if he was born so much IUGR or SGA. So those children, actually, we don't subtract this gestational age because they usually catch up. Okay, so let's not go into that. Most importantly, if the baby is born premature, you take the correct gestation age. And chronological age is same as calendar age calculated from date of birth. Okay. Then comes your history. So we were discussing about whether the child has, when have they started observing that the child is short, and do they feel that the child has any systemic illness, right? So we will take history of systemic illnesses. So like respiratory distress, like recurrent chest infections, any history of polyuria, which can be suggestive of a renal tubular defect, recurrent UTIs, any recurrent infection, any recurrent, kind of illness is going to hamper the growth of the child. Suppose he keeps getting admitted every, say month, 15, 20 days. So obviously he's not going to grow to his full potentials. If he has a chronic abdominal pain, due to which he's not able to eat, he has a chronic diarrhea, he has a malabsorption, he has a celiac disease, he has chronic constipation due to which he's not eating, he has a CNS problem like a visual defect, he has a malignancy in the brain, recurrent vomiting. So all these, any systemic illness, so you can include these as red flag signs. So any red flag signs you have to look before we say it is some non-pathological cause of short stature, like we label it as because the parents are short, that's why the child is short. So before you say that, you have to rule out all the possible pathological things you can think of. Also, we'll come to that physical examination also. So, okay, so that was the systemic history. Then comes your natal history. Natal history, we'll ask about what was the birth weight of the child. Same way, like was he short? What was there any neonatal hypoglycemia? Is there any metabolic problem? Was there any prolonged neonatal jaundice? Has the child has a metabolic problem or has a neurological problem at birth? The child is a cerebral palsy child. All that concept you have to come out in. Okay. Next is your dietary history. Is the child not growing because he is not getting enough nutrition, which is a very important factor in our country, especially. So maybe the child is not getting enough proteins and calories, right? That is why he is short. The parents are not able to, or they don't know what kind of food to give to the child. Then is your family history. Is the family also short? Is the father short? Is the mother short? Or, further you can ask, are the maternal or the paternal relatives short? So that can help you. So once you do that, you will also calculate the parent's height. You also inquire about the parent's age of puberty. You ask about history of short stature and chronic disease in the family. So celiac disease, all these autoimmune diseases, diabetes, all these run in the family. So maybe the child is short because the father is a patient of celiac disease. He also has the same genes. So he is also having celiac disease. Maybe he is not symptomatic by now, but yes, he has it. That's why he's short. So history of delayed puberty or growth, or history of any consanguinity for any genetic or metabolic disorders, right? Okay, so we'll go ahead, I think. Yeah. So this was the approach. We'll go further in the approach. We took the age, we took the history. So this is step one, don't forget it. Date of birth must on every child who comes to you in the OPD. First thing, date of birth, okay? Then you take the history. Then you come to the psychosocial history. So psychosocial history can contribute because there is not a conducive environment for the child at home. That's why he is not growing well. There is some family abuse. There is some family dispute. That is why the child, all diseases actually are affected by environment, right? So when the environment is not conducive to the child, he won't be growing well. So psychosocial history you need to ask. Okay. So then we come to examination. To look for any dysmorphic features. Height, you've already, I'll tell you how to take the height. First, this is the general physical examination. To look at the child fully. Does he look dysmorphic? Does he have some doll-like faces? Is he like pinched out nose? Any dysmorphism, just note it down. Okay, then whatever systemic history you took, you look for the systemic signs as well. Does he have a respiratory problem? Is his chest collapsed? Does he have a precordial impulse? Is there, an increased precordium? There is a murmur. due to which he is not growing. Then there is some renal problem, there can be palatable kidneys present. There is some CNS problem, you have abnormal tone, reflexes. So do a full systemic examination, okay? Then you look for signs of puberty. So this is another thing, sexual maturity rating. This is mentioned in your books. I hope you are aware of it. So this is a must in any child who comes to you with short stature, especially in an adolescent child beyond 9-10 years of age, to look for whether secondary sexual characters have been started appearing or not. Also, most importantly is of course to see whether the child has attained secondary sexual characters. Sometimes there can also be precocious puberty. Okay. So in a younger child also, you need to see the SMR if he is presenting with short stature. Otherwise, in exam, if you have an adolescent patient like a long case, then always do the SMR. It adds to the value, and it is a good concept that you should include. So SMR is one thing which you should cover. So I will not go into the details of SMR because that is a whole soul another thing, but it is done by Tanner staging. There are 4 stages of SMR. It's different for boys and girls. It is based on various concepts like hair development, breast development, and the development of various secondary sexual characters. So go through it from your books, right? So Tanner's staging you must know. Okay. This is SMR or sexual maturity rating by Tanner's. Also look for any thyroid enlargement. Is the child short because he has a thyroid problem? Or, this is a very common problem. All of you are aware that hypothyroidism is a very common disorder and it commonly contributes to short stature, right? Then there can be some short fourth finger. That is actually, these are all syndromic features. So look for any syndromic feature. You find a webbed neck, you find an increased carrying angle in girls. Turner syndrome is very common. Okay, Down syndrome features. If you find Down's children are also short, so look for dysmorphism like we discussed, Mongolian slant, flat facial profile. Okay, look for the simian creased, short fourth finger, clinodactyly, subtle visual defects for any cranial ixol. So look for all possible dysmorphism and any digital problems that can give you an idea about if any syndrome is present. Also, most importantly, look at thyroid. Okay. So next we come to taking the length and the height. So you have already had this class actually, how to measure the length. So I won't go into the real details of it, but I think this is an infantometer, and this is how you let the baby lie down on the infantometer. So usually till 2 years of age, we take the length, and above 2 years, we take the height. So 2 years, and this is how from the vertex, that is the highest point, to the soles, measure to the nearest 0.1 centimeter. So most important, you need 2 people. So if somebody asks you in exam, show me how to measure the length. So you say, I would need somebody to help me out, okay? So that you have 2 people. Or if there is nobody to help you out, you can ask, I would need the mother or the attendant to help me out with measuring the length. One cannot measure length on infantometer alone. Okay, so this is an important thing that you need to note. You need help of somebody, either either you need help of your okay, so either you need help of an assistant or somebody to help you out, a staff nurse or somebody, and or you need help of the mother. Okay, so this is how you measure. And then what you do is you fix the headpiece. So the one who is more experienced, that is you, will stand at the foot end, and the mother or the person whom you have taken for assistance will stand at the head end. You will stand at the foot end because this is the one that has to move. Okay, this is the movable foot piece. The leg should be extended. So if the leg of the child is difficult to extend, you can use one leg to extend it, because children are crying and it's difficult. Okay. So we'll just quickly cover this because we have a lot to cover. So height, the Frankfurt plane, this is a stadiometer. Okay. Standing height is measured between the vertex and the floor. Okay. And okay. And head is in the Frankfurt plane, right? Then this is the points, the back of the head, the scapula, the buttocks, and the heels have to touch. Okay. So I think you know this concept. We'll go ahead. And heels back together. So now you've calculated the length, you've calculated the height. Then we calculate what is the height age. Okay, so what is the height age? Height age is the age at which the patient's height is at the 50th centile. I'll give you an example. Okay, this is the growth chart. Okay, so this is a WHO growth chart. I hope you can see this. So the child is, say, this child is 10 years and his height is here. Okay, that is 120 centimeters. Okay, so you see that the height is less. I hope all of you can appreciate that. At 10 years, 120 centimeters obviously is less. When you even calculate by doubling, tripling, which we don't usually use, but the child is almost 100 centimeters by 4 years, right? So 120 at 10 years is definitely very short. It is quite apparent. So he is, as you can see, we use the height for age chart. So you need to choose which chart you will use. You will choose height for age chart for boys at this age. So the correct chart at the correct age and for the correct gender. So you chose that and you found that the child lies less than the third centile. Okay. This is the third centile. Then what do you do next? Okay. So you plot it like this. You see it's coming less than third centile. Then is the concept of your height age. Okay, so his height age is 120 centimeter is the 50th centile at what age? So this is the 50th centile. Trace it to 120 centimeters like this and then plot it here. So you see it's 7 years. So actually the child is 10 years, but his height age is 7 years. So he is as tall as somebody who is 7 years of age. So that is his height age. Does anybody have an issue with this concept, or I'll move further? Have you understood what is height age? Can you just answer in the chat box so that we move further? Okay, we'll move further because we don't have much time. So this is the concept of height age. So this child is 10 years, but when you calculate his height, what it is at 50th centile, it's coming out to be 7 years. Okay. So his height age is your 7 years. So chronological age is 10 years, height is 120 centimeter, which is less than the third centile. Okay. Okay. And your height age is 7 years. So what do you do further? We calculated the height age. Then you see the body proportions. It's very important whenever a short child comes to you, you calculate the upper segment and lower segment. Did you see this before, how to calculate the upper and lower segment? I'll just repeat it quickly. So upper segment, there are two methods of calculating. One is the simple one, measure from the pubic symphysis to the floor. This is the lower segment, subtract it from the height, you will get the upper segment. So upper segment, lower segment. And what is your another method is you make the child sit down. So measure from the this head vertex to the stool. This is your upper segment, okay? And measure from here to the floor, that is your whole length, and subtract the stool's height, that is your upper segment. So this will be the upper segment, minus it from the height, that will be your lower segment. Okay. Okay, so we'll move further. So this is the normal upper segment, lower segment ratio. I won't go into the details. This is just theory. We know that at birth it is 1.7 and gradually by 7 to 8 years, it's the adult proportion. Okay. So by what age, upper segment, lower segment, there is a disproportion. It can be in rickets when upper segment is more. In hypothyroidism, upper segment will be more. In achondroplasia, upper segment will be more. Okay, in your arachnoidally spondyloepiphyseal dysplasias, mucopolysaccharidosis, your lower segment will be more. Pot spine, lower segment can be more. Okay, we'll move further. Any questions till now? You can just put in the chat box if anybody has any question. Okay. So we were doing the anthropometry, we took the length and the height, age. I hope you have understood the concept. Then we calculate the body proportion. Then you calculate the arm span. Okay. So how do you calculate the arm span? Yeah, 1 second. Yeah, so it is between the distal ends of both the middle fingers. Ask the child or the adolescent to stand with his outstretched hands, okay? And the distance between the distal end of two middle fingers is going to be your arm span. Under 5 years, arm span is less than height by 2 centimeters, and gradually, it keeps increasing. So by 10 to 12 years of age, it is going to be arm span is equal to height, and after 12 years of age, arm span is going to start exceeding your height by 1 centimeter. And if it exceeds too much, more than 2 to 3 centimeter, or actually much more, then it is Marfanoid type of phenotype. Okay. So if it is more than height, it is a disease of the vertebra or Marfan syndrome. If it is less than height, it can be achondroplasia or hypochondroplasia. Okay. Okay. So we did the length, we did the height, we did the body proportions, we did the arm span. Weight you can do so that the weight for height and BMI and all. I won't go into weight. Okay. Next is your bone age. So this is another important concept. You all need to really concentrate at these slides because bone age is a concept which everybody needs to know. So bone age is when we get the X-ray of the child, depending on what age he is, and see according to the bone that what does his age show. So in the newborn, we do X-ray of the knee. At various age, you do various X-rays. In infant, you do X-ray of the shoulder. So if a child is just born on say 6 months of age, you will do X-ray of the knee. Usually infants rarely come to you with short stature. So X-ray of the shoulder we are rarely doing. So by newborn we do X-ray of the knee, and beyond that we do X-ray of the hand and wrist. And above 13 to 14 years of age you can do elbow and hip. So most routinely we are doing knee, and next mostly adolescents are going to come with you. So you do hand and the wrist. So this is the X-ray which you mostly do is your knee and your hand and wrist, right? So this is the concept of bone age. So what do you see in these X-rays? So there are two methods of seeing X-rays, and you should all gradually learn to see X-rays. because bone age is, without bone age you cannot estimate anything. So first is of course taking length, which is basic, then is taking parents height, I will mention that also, and you know, plotting the height, which is very important, plotting the height age, upper segment, lower segment, arm span, and then is your bone age. So this is also an important concept. If you should not know in detail, at least you should know that we do the bone age to know whether the child is short because of some pathological reason or a you know, constitutional or familial reason. So there are two methods, this GNP or Gurlich and Pyle method, on Tanner and Whitehouse method. So both, what you do, you compare with the atlases. So atlases are available online also, and you know, textbooks are also available. So you can compare with the atlas. And in Tanner and Whitehouse, it is more reliable, but it is a bit difficult. So you look at various regions of interest in the bones. And in this GNP method, what you do is you just compare it with the age. Does it look like 15 or 16? 13 or 14? So that way you can see. I'll just show you. So this is Tanner and Whitehouse method. I don't have a picture of GNP method. That is much easier. So there are these 10 regions they have shown in this. So 1 is this region, 2 is this phalangeal region, 3 is this, 4 is this phalanx, interphalangeal joint. So you look at all of them and compare it with the X-ray that you have got and see, is it is it matching with that, or do you need to look into the previous one? So say they have not mentioned the age, say the child is say 10 years of age, so first you compare with the 10 years. So you feel that his bones are less developed as compared to 10 years. Then go back to the previous one. Okay. See, compare it with 9 years. You see that 9 years also he is not matching that. Go to 8 years. Go to 7 years. So, you know, you can match it with that. And same is with your GNP method. It is a bit easier than this. This is, you know, you have to look at several points here. You can see 1, 2, 3, 4. In that, you just look at major bones. Okay, like these carpal bones. You should just know how to do a bone age. Okay, yeah. So this appears, this is how you do it with the, you know, carpal bones. Like the capitate appears in the first year, hamate first year, triquital, pisiform. So what we see is the pisiform. You know, mostly children will come to your 10, 12 years of age. That's what I previously mentioned. So if you see the pisiform, yes, he is 12 years of age. You don't see the pisiform, he is less than 12 years of age. So his bone age is less than 12. If he say 16 and pisiform has not appeared, he is less than 12 years on bone age. So what is the benefit of this bone age is what we're going to discuss in the next slides. I think we'll quick it. So bone age, what is the concept of bone age helpful in? It predicts the adult height. It helps in knowing whether there is a pubertal disorder. It helps in differentiating these two types of short stature, which I'll discuss. One is familial and one is constitutional. It helps in diagnosis of precocious puberty. So what will happen to bone age in precocious puberty? Meanwhile, you just put it in the chat box and I'll go further. So what is the problem in precocious puberty with the bone age? Can somebody just answer in the questions? In the questions, can somebody answer? What will happen to bone age in precocious puberty? Will it be delayed or will it be, you know, advanced? Okay. So whether to start therapy for hypogonadism, to monitor children on growth hormone therapy. So nobody is answering. What will happen to bone age? So bone age will be advanced in the child with precocious puberty. Okay. Yeah. So then is the concept of calculating the mid-parental height. So whenever you get a child with short stature, calculate the mid-parental height. Ask them to bring the father or the mother, both of them. Take their height like you routinely take height on stadiometer. For boys, you divide by 2 plus 6.5. For girls, you add their height and minus 6.5. So what do you do after you get the mid-parental height? I think all of you know how to calculate the mid-parental height, but what to do after you get the mid-parental height, okay? You are going to see the target height, okay? So what is the target height? The target height is the height the child will attain at his full growth potential. That is at 17 to 18 years of age. So whatever height you get, this is the adult height. So say the adult height comes out to be, say, 150 centimeters. So 150 plus minus 5 is going to be the growth potential of the child. He can also be 155. He can also be 145. Okay. So this is the target height. And where you plotted it as on the growth chart is at 17 to 18 years. Okay. This is where you plot it is important. Everybody knows how to calculate MPH, right? So child is 120 centimeters, same child. You calculated the mid-parental height. It was 157 centimeters. Okay. Sorry. This is his extrapolated height. If he keeps going at this age, this is the extrapolated height. And this is where his mid-parental height lies. So what do you think? This mid-parental height is he reaching his full potential here? So it's very low, 175 minus 5 is 170, plus 5 is 180. So he is nowhere here, right? So you see where his growth chart is lying, and then, compare it with the mid-parental height. So it's very away from the mid-parental height, as we can see, right? So we'll just go quickly to the causes, and we have 15 minutes left. So, in the normal variant, we have a constitutional growth delay, and in the other one, we have a familial growth stature, short stature. Okay. So familial short stature is when the growth velocity is normal. Okay. The target height will be within the calculated range. Okay. So in familial short stature, what is actually happening is that the child is short because the parents are short. So when you see this growth chart that I showed you, this is definitely not familial short stature because the parents are tall, but the child is short. So this is not familial short stature. Familial is when the parents are also short, right? So the growth velocity will be normal. The pubertal age will be normal. The bone age and the chronological age are going to corroborate, which we discussed the concept of bone age. Here is the utility of that bone age, of getting that X-ray and looking at those bones. So final height, as you see, the parents are short, so the child is also going to be short. So there is less than minus 2 standard deviation. Final height is going to be, and family history of short stature will be there. That almost all the family members, or say the parents at least, are short. So this is familial short stature. So what you need to know about familial short stature is that when such a kind of situation comes to you, you have to counsel them that you can, make the child tall up to the potential, which is his natural potential. You cannot stretch him beyond his natural potential. So the natural potential of the child is to grow to a height or a mid-parental height, which is of the family, and not beyond that, right? So environment can be modified up to some extent so that he grows to his best growth potential, but not beyond that because the family is short, right? So this is the concept of familial short stature. Next is your constitutional delay. So this is another important and common problem, which is a constitutional delay. That is, the growth will occur, but it will probably occur slowly. The growth velocity is slow. The puberty is delayed. And when you do the bone age in this kind of patient, the bone age will be delayed. Okay. So, and the final height will be normal. So there will be family history of delayed puberty and delayed growth spurt. So what is occurring in this patient is that everything is occurring slowly or delayed. He will grow. So the counseling between the two types of short stature, you need to know, is totally different. In the familial one, you are going to counsel them that your child, this is the best growth potential of your child, and he is not going to go beyond that. However, in this one, What you need to counsel is that the child will grow. Like you probably had a delayed spurt, your child will also have a delayed spurt, but he will grow. So you understand the difference is so much in the counseling, right? So you need to know what is the difference between the two. Okay. So I think you need to answer now that which one is which. So this one. So this child, you can see he is growing, he is short, and then he always remains less than -2 standard deviation. So can you answer what is this? The one I'm showing, the purple one, light purple one. What sort of short stature this is? This is familial or this is constitutional. His final height is less. He is continuing to grow on his centile. I'm looking for answers, but nobody is answering in the questions. So what is the child with purple graph showing? Okay. Yeah, so actually maybe I'm not able to see. Your answers come like this. There are more questions actually. Your questions come a bit late. Let me just go through. What does it represent? Prematurely we have answered. So somebody said purple is familial. Okay. What is the significance of height age? Below what is it significant? So height age just shows that the child is short. Ma'am, is it possible if one that will be a cause of familial short stature? Uh, Okay, we'll just go through. First, I think I'll go to your questions later on because I just saw that there are several questions. And then first I'll just cover this. Okay, so your purple one, as somebody rightly said, is your familial short stature because he is growing along his growth potential, right? Then your blue one is your constitutional one because he was going slowly, 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 and then he had a growth spurt and reached his potential. Okay. So I'll go to your questions. We'll just complete this. So this is your normal variant. You understood about the counseling. Pathological ones are rare, but you need to look for them. Dysmorphic, chromosomal problems, SGA, IUGR, Natal causes. Postnatal causes may you have to see whether there is an increased weight or a decreased weight. So if the weight is increased, there will be hormonal issues like hypothyroid, growth hormone deficiency, some steroid intake. And if it's less, then probably it's a systemic illness. I think this is quite sensible. If the child is not growing well, he has a systemic illness. Obviously, his weight is also not going to grow according to his height, right? So disproportionate, we already discussed. Upper segment, lower segment, we discussed this point. So with dysmorphism, we already discussed Down syndrome, very common, look for it. Turner syndrome, look for it. Web neck, female child, very short, amenorrhea. Then Noonan syndrome, similarly, Russell-Silver, Prader-Willi. Keep looking for all these subtle signs. So this is just to show you what are the common causes in India. So most common, as I discussed, is the normal variant. That's why we discussed it in detail. A large proportion is the normal variant, or we call it constitutional or familial. So you can see about 30 to 40% are normally because their parents are either short or they will gradually grow. They are constitutionally short. Okay. And next is your hypothyroidism. studies did find growth hormone, but I would stick to hypothyroidism. So screen for constitutional variants, screen for thyroid, basic. And also, which they haven't mentioned in this, is celiac disease. So screen for celiac disease, especially in North India. These are studies from other places, not North India. So screen for your celiac disease, very important. Okay. I'll just see your questions after I complete my slide. So this is just an approach. Short child, do a history, do a physical examination, growth velocity, do height, age, bone age, target height, SMR, to take a clue. Is it constitutional? Is it familiar? Counsel the parents. No, you don't think it's that? Then go with your workup. Get it. Sorry, hemogram, get your targeted test, RFT, LFT, calcium, phosphate, blood gas, depending on what you think, not for every child. Don't do this battery or tests on every child. Do a bone age. Okay, we did the bone age here only on here. Bone age is the first step. So if normal, preferably, you should do karyotype for all females, but this is a concept from the West. I would say do TTG first, more common, and this you can do later on. TTG thyroid come first. This is I have taken from a Western literature, so it is different. But TTG thyroid do first. Otherwise, for female child, yes, karyotype should be done if affordable, if available, because turners may be subtle and may be missed. Okay, so abnormal, you go on to your specific test. So then we do management. Counseling and reassurance of normal variants we already discussed. Management of specific systemic illness, patient has heart disease, cystic fibrosis, treat that. Nutritional rehabilitation, we discussed if there is the child is not getting enough nutrition. Social rehabilitation, if there are psychosocial factors contributing, treatment of infections, UTIs, hormone replacement, if the child has hypothyroidism, growth hormone deficiency, uh, insulin-like growth factor, androgens, aromatase inhibitor. Surgical, we rarely do, but yes, it is mentioned. Okay, so just a line about growth hormone deficiency. It is a congenital or genetic cause. The children are normal. There may be history of neonatal hypoglycemia. We discussed. There can be a micropenis. There's midfacial crowding, ball-like faces, and growth retardation is usually by first year of age. Okay. So rule out other causes. As we said, 30-40% are normal variants. Stimulation tests you can do with various agents for growth hormone like insulin, arginine. You need to stimulate the growth hormone and see. So this you don't need to know in detail, but you should know there is something known as growth hormone deficiency, which commonly presents to the endocrinologist, and you have to do stimulation test. You cannot do growth hormone like thyroid hormone. Okay, get the child, let's take out the growth hormone. No, growth hormone has to be stimulated and tested. Just that much you need to know. And there are some conditions where growth hormone is effective. We cannot give growth hormone to a child who has a familial growth stage, short stature. He's not going to grow with growth hormone. He doesn't have deficiency. So these are few of the growth hormone indications which are FDA approved. Of course, growth hormone deficiency. Sometimes in idiopathic short stature may be tried. Now it has come up because it is sort of driven by growth hormone, and SGAs, Turner's, Noonan, especially syndromes, CKDs, you can give growth hormone like your CKD children, and AIDS cachexia also. But mostly we are giving for syndromes and SGAs, and of course growth hormone deficiency. So we'll go to your questions and this spot diagnosis. So I'll just go through your questions and you can tell me what this thing is. So anybody, what is this? So can anybody answer? What is this child? Most of you have answered advanced. Somebody said Beckwith Wiedemann. Yeah, he does have coarse faces, but still, anybody else? Look at the faces. Yes, somebody has mentioned he has coarse faces. He has a distended stomach. Okay, yeah. So he has a coarse facial profile. I think all of you can uh, appreciate that. He has a coarse facial profile. Okay, so this sort of facial profile can also be seen in your, one of you, what did you mention? Beckwith Wiedemann. Yeah, it can be seen, but look at the facial profile. It is coarse. Look at the neck, it is short. Look at these hands. Okay, so there are short, stubby fingers. Okay, so this is a child with your mucopolysaccharidosis. Okay, okay. Somebody asked if bone age is height age. I told you there is no cutoff for this. Yeah, initially that is the normal concept that height will increase, but later due to fusion, of course, height will stop growing. That is true, but has to reach its potential, right? Initially, that is the growth spurt we discussed, that there will be, that is a normal concept of growth, that initially the height will increase at the growth spurt, but then it will stop. But what you saw in the constitutional growth stature is that it is growing below the centile, and then there will be a sudden spurt. There will be delayed everything. There will be a delayed puberty. There will be a delayed height spurt. So when everything is slow and delayed, that is your familial short state, constitutional short stature. Sorry, not familial. Familial is he's always short. So if a newborn has height, has normal, how can he ever be short stature? So you are saying if the child has 50 centimeter and he has a normal growth velocity, can can he can it ever be short statures? Yeah, because suppose the newborn period, the child did not have any manifestations. Suppose he developed autoimmune thyroiditis. Okay, so of course he can be short. When does autoimmune thyroiditis develop? When the child is your uh, an adolescent. It is a disease of adolescence. Okay, anything else? I think we covered this. Okay, coarse facies, umbilical hernia. Yeah, that's good. This is a child with mucopolysaccharidosis. So can anybody tell what is this child have? Look, just describe the child. What do you think about the upper and the lower segment? If you look at the child, does the upper segment appear a bit longer to you? Yeah, so somebody answered. Second. Okay, disproportionate. Yeah. So this is disproportionate short stature. Somebody said cretinism. So cretinism is when there is congenital hypothyroidism. What I wanted is that is he disproportionate or proportionate? So he is disproportionate. Your upper segment is higher. So it can also be thyroid. It can also be achondroplasia. So both of you have answered correctly, but what would be better was be a disproportionate short stature, which is has answered. Your colleague has answered. That's good. At least you are picking up. So this child had actually achondroplasia. So what about this child? First tell me what all do you see in her? So she is a female child. What all do you see in this female child? Achondroplasia, a lot of people have answered for the previous one. So what do you see in this child? Then we'll just finish. So somebody said arm span is more. Okay. Anything else? What is with the neck? Do you see a web neck? Yeah, cubitus valgus is there. Okay, that's good. We see a cubitus valgus. We see a, web neck. Also, yes, shield-like chest. Okay. So a lot of you have answered that correctly. So this child, she's a female child. So she has a shield chest. She has a cubitus valgus. She has a web neck. If you who do her ultrasound, she will have a striate ovary. So this is a female child with Turner syndrome. Okay. So that's it. So just a repetition. Look at the growth chart. See the height, see the weight, see the bone age. So if you see that the child is short and heavy, more of endocrine causes like thyroid hormone deficiency, cortisol deficiency, okay, cortisol excess, sorry. If the child is thin, then of course he has a systemic disease. If the child has short with normal velocity or a slow velocity, like in your constitutional ones or a normal variant. So if height age is less than bone age and equal to chronological age, height age is equal to bone age less than chronological age, and bone age is less than height age less than chronological age. So then it is familial, this is constitutional, this is pathological. Okay. So what is the guidelines for monitoring growth? That for every child up to 18 months, you should do it at immunization visits. That is 6 weeks, 10 weeks, 14 weeks, then 9 months, then 1 year, 15 months, 18 months. Okay, so at immunization visits. So grossly in the first 6 months, every say, 4 to 6 weeks, and then, every 3 to 4 months. Above 18 months, you can do it 6 monthly so that you know the growth velocity, because we will do T2 minus T1 divided by the months into 12 so that we know the growth velocity. And for older children, you have to do it annually. Okay, so any other questions? We come to the end of the class. Yeah, so a lot of you have mentioned Turner's. Yeah, I think we'll end the class if there is no question. Okay, thank you for your attention and have a good day, all of you. Okay.